We are live.
Hi, everybody. Good to see you all again. We're missing one of our people here today once again, Lisa Cush in Canada, who's been dealing with her ailment, as you already know. Hopefully, she'll be back with us very soon. And just again, I'm Peter Litchfield, as you know. This is Sandra Reamer and Wolf Fellner. We're all on the board of On the Air of Breathing Science, our nonprofit organization. And we really appreciate your support in listening to our programs, attending our programs. Most people are listening to the recordings. We encourage you to come and interact live and ask questions and so on. And so we have a guest here today who Sandra and Wolf and I know very well. She's a colleague of ours, Denise Campbell, who's been a colleague of Sandra's of mine for 22, 23 years, something like that, I guess 22 years. She's been doing breathing behavior analysis for many, many years. She owns a number of different physical therapy or physiotherapy clinics in southern New Mexico and in northern Texas. Very, very active practice. She also has a women's center, and she has a very wide-ranging practice. They see many kinds of cases that we'll see something about today, because our focus today really is breathing and pain management, or just how breathing interacts with the whole phenomenon of pain, as well as how we do breathing behavior analysis work in physical therapy itself, not just pain management, but she'll be integrating a number of things that she may be talking about. And we'll be interacting with her. It'll be a conversational kind of a setting, as it has been in the past. So I'm going to just turn it over to Denise so she can kind of introduce what she wants to bring to our conversation today. Denise?
Thank you, Peter. Yes, the topic of pain has been central to physical therapy my entire career, right? I mean, that's why people usually come see us, unless something's, broken and without pain. That doesn't normally happen, right? But it's been a fascinating journey. And then over the years, studying pain and the neuroscience of pain, that's a big buzzword in the last 10 years or more for physical therapy. We've actually kind of evolved. When I first was doing this, you couldn't do cognitive behavioral work in PT. There's no way to bill it or do. So now we have some of those things. We've done a lot of work with the APTA, and there's still more work to do. That's our American Physical Therapy Association, to make sure that, we can do the things that we have learned in our practice. So I'm a sports medicine and spine specialist. My original company was named Southwest Sport and Spine. So I see a lot of chronic pain in the spine world: headaches, neck, spine, multiple surgeries, car accidents, sports injuries, people that were once greatly active one day and now they can't walk the next day, right? So that is a huge change for a lot of people, just for their whole being. And so we've seen just all different kinds. And then when I found out about capnometry and met you, Peter, and started learning about the breathing sciences and the CO2 and how important it was and how to measure it, then it was just a natural intervention into my practice. I'm a mechanical diagnosis and therapy practitioner. As far as a system that I learned early on, I have my diploma in that. People will recognize that as the McKinsey approach. It's a systematic approach to spine pain as well as extremities. And part of that is education, right? We're big on self-treatment, enabling people to treat themselves, go on, because there's not enough we can do just in an hour. It has to be in partnership and therapeutic alliance with the patient. And what I realized, first of all, in understanding the effect of breathing in CO2 levels on pain and just the presence of my patients. In therapy, I realized that some of them weren't able to hear me or process because of the states, the physiological state they were in with the low CO2. And so that just started this now, I guess, almost half my career or more now has been looking at how this aspect of normalizing physiology and looking at people's CO2 and helping them work through some of the ideals of their pain has really become a big part of my practice.
Right. Yeah, I was going to
Well,
ask you, Denise, when you mentioned just recently about when clients come into your practice and they have all kinds of symptomology. I was wondering what ways do you utilize to identify if someone could have learned some kind of breathing that's contributing to their pain when they come to the clinic?
Yes, that's a great question because my philosophy is trying to identify their greatest barrier to recovery as quickly as possible. And then you kind of attack that barrier and then you go the next barrier and the next barrier, right? And what I realized as I was working with breathing, that sometimes that is their greatest barrier to recovery, day one. And so myself and the other therapist are trained to see some of the symptoms, kind of peel that out from people as far as um, maybe things they could tell us that point us in that direction, as well as just kind of how they look. You start to be able to pick up people who are severely hypocapnic. And then the other thing we did was we use a system called PHOTO. It's focused on therapeutic outcomes. And back in 2011 and 2012, we did a study where we looked at consecutive patients coming in and ran a baseline, and we realized that 66% were hypocapnic.
just
And
to
one of the big,
interrupt for a second, we need to remind people what hypocapnia is, because a lot of people
okay,
attending here have
okay.
no background whatsoever. Though we've talked about hypocapnia, we should make sure that people remember what it is. It's basically low levels of arterial carbon dioxide. The concentration of carbon dioxide is too low. And when it's too low, you get all kinds of radical symptoms. For example, when she was making reference to her patients who couldn't really hear what she was saying during therapy, you have someone who's hypocapnic. It means there's a deficiency of blood supply to the brain because of the low carbon dioxide levels. You get vascular constriction and it reduces blood flow and blood volume in the brain. You become disoriented, you become hypoxic, you become there's low levels of glucose as well as low levels of oxygen, and the blood, the hemoglobin isn't delivering the oxygen properly. It isn't distributing it properly. Person becomes disoriented and then doesn't remember what they're talking about. It may exacerbate pain. They may become emotional because of what we call disinhibition in the brain, all kinds of things that happen. So this is hypocapnia. Just want to remind you in case you weren't here at some of the earlier sessions. Sorry about that, Denise.
Oh,
Go ahead.
great. And that's good because that's baseline to understanding kind of what we're talking about. So, um, when we see the changes in blood supply of the brain, there's of course a cascade of events as you just well described. But what we found was seeing that people were low just coming in, like to start out with. And then on focus on therapeutic outcomes, we actually did another study where we looked at back pain and SI joint pain, and we created categories of when you would need or know for sure that you needed to look at their physiological states with their CO2. And one of the big ones was that if they had chronic pain over 6 months, right? If they said their severity was severe, and if they had high fear, right, on a fear avoidance questionnaire, it's a common questionnaire we use in therapy, used it for years and years, that, and they had neck pain or upper back pain or something, then like 85% of them were moderately severely hypocapnic, right? So when you're asking Sandra about how do we kind of know, we've done enough to wait. Yes, you can see the person, you can start to see signs. We can pull the questionnaire that we use and start to kind of glean that out a little bit more on day one or day two. But we've also been at it long enough that we can see like a pattern, right? That's going to really kind of predict that this is going to be involved, and you need to address that first.
Okay. Are you using any instrumentation or are you just using surveys at first or forms?
Now we use the instrumentation we use the Capno trainer, Capno Go. We have several in the clinic. The therapist can choose to run them through a 15 or 20-minute assessment on their evaluation. But most, if you see that it's really severe, or you do it the next session. And then once we see where they are, then we have prescribed protocols that we use. Sometimes it's just like the main barrier, like I described. So we really have to get them to a place where they can be effective in therapy, or it's just an enhancement. Maybe it's mild. Maybe it's just them coming in there talking about their accident or how bad their pain is or what's going on. And then we can do 2 or 3 sessions, like a 15 or 30-minute workup with them with the Capno trainer and get them in a better state. Or they just need to have 6 straight sessions, depending on how severe it is, before we really go on and add other things in therapy.
Mm. Okay, great. Yeah, thanks for laying that out a bit. It helps us understand when someone comes into the clinic, how do you identify if breathing is a factor? Is it just observable? Are you seeing something when you're watching them? Are you using equipment? Are you using
Yeah, really
forms,
all of that,
surveys?
all of that. And then also to know that just the science and the physiology behind it. So we also have a balance center, for instance, right? And we treat people with balance disorders, disequilibrium, vestibular, and we know that the blood supply to the vestibular system is very small and kind of tenuous. It's easily affected by blood supply. So actually, there's one section that we know that in the old terms of hyperventilation, overbreathing, low CO2, that brings on and perpetuates symptoms of dizziness and disequilibrium. So we know in that setting, we need to look at it, right? We also need to see that with our chronic pain patients. We know it's a big factor in concussions. So, and then now we kind of know one of the things when I was talking about the 66% of the people coming in, it was amazing that many of them were knees, which I would have never suspected, right? But if you think about it for yourself right now in your life, if you hurt your knee, right? And now your ability to walk, get around, go places, do your job, it's pretty traumatic and concerning to your system. Like, how am I going to get through this? What's going to happen? And I think that's why they have a little bit more of that than what I suspected. So that background as therapists that we learn helps us also to kind of cue that up as a question and a factor that might be going on in specific patient populations.
Well, you wonder why it is that so many people who have knee issues also have a breathing problem. And so I could make a comment on that, and that is that people basically learn dysfunctional breathing. They learn dysfunctional breathing habits, and those habits are based on something. They're based on an experience that a person is having or had, and maybe they had it, and then they carry forward that habit into other circumstances where they experience the same kind of challenge or stress. And so when you have a knee problem and it's difficult to get around, you can imagine a lot of people take over their breathing. They try to do something with the breathing, usually unconsciously, but it may be conscious as well, where people reach for more air. They may hold their breath when they try to walk. Maybe they try to take larger breaths after they've held their breath very briefly. Holding the breath very briefly isn't going to do anything, but it may essentially bring on air hunger just simply by the fact that you've held it for a few seconds and now you reach for more air and then you lose carbon dioxide. So that the actual knee issue sets the stage for learning a habit that creates a problem. And that, by virtue of metaphor, can get built into other parts of the life of life where the person then takes over the breathing as a way, as part of a pattern in coping with a particular challenge. And what do you think of that, Denise, in regards to what you
Yeah,
see?
definitely, definitely. Of course, there's and if kind of what's at stake too in that like what is at stake for that individual with that knee problem, like kind of brings on a lot of stress related and dysfunctional breathing patterns, that we shift into when we're stressed, when we have things we can't get away from, all the things we see with all types of patients. And then other things, even mechanically, that start to affect their breathing besides their habits and their behaviors. I don't know if you've ever been on crutches, but I was on crutches for 9 months as a teenager. And biomechanically, it changes the way you breathe because now your shoulders, are becoming a closed chain type system. It's a lot of different things to look at, but that's definitely from a behavior standpoint and what we can do some things about. It's definitely a factor for sure.
Yeah, it's one thing to really understand is how we learn to respond to challenges, all the different behaviors that come into play, one of which is breathing. And unfortunately, when you compromise breathing, the impact can be profound as compared to other behaviors that may influence you, but not in the way that breathing does, where it participates in almost every dimension of your physiology in ways that generally aren't recognized by the patient or by the therapist, not understanding the interaction that's going on. And when you get the symptoms associated with that hypocapnia, then they get misinterpreted and attributed to other things rather than to the behavior of the client or the patient. And one other thing that's really important to understand is that it isn't necessary because you have stress that therefore your breathing is, from a respiratory point of view, is going to be compromised. It doesn't have to be compromised at all because you're stressed. What's critical here is the behavior that you learn in response to that stress, and you don't blame the stress, for the dysfunctional breathing. It just sets the stage for how you behave, which in turn then affects you. And I think that's really an important distinction when you're working with someone where, around breathing and pain and, physical disability from my perspective.
Yeah, it's very critical. And sometimes just that, Peter, that explanation to them in those first one or two sessions, recognizing and helping the patient understand that we understand the change in life and what can happen, but it's still we have responses and they don't have to have a negative effect on the rest of them. And once they realize they have that control and just have that basic education and a little bit of that, then they start to like come back with that. It's like, okay, I'm not set like this. This is just a response and I can change it. And just that alone, and that's what we do a lot with pain education. It really helps that patient and client just already start to move toward a more homeostasis with their breathing, right? Their breathing
It would
physiology.
be, unfortunate to think that the reason you're breathing dysfunctionally is because you have pain, and therefore the only way you can deal with a dysfunctional breathing is by getting rid of the pain. And it really, that would be a very unfortunate kind of understanding because it's really about you can have pain and have good breathing. And if you have good breathing, you're likely to have less pain because, dysfunctional breathing can exacerbate pain that exists. It can also bring you over the threshold for pain, where you otherwise might not have the pain, but it brings you to a place where you start to experience it, where, that pain being based on an injury or something like that. So it interacts, it can trigger pain associated with a disability. It can also exacerbate the pain and so on. And what's so important to understand that dysfunctional breathing isn't a necessary outcome of the pain, that your management of that breathing or your essentially allowing the reflexes to regulate the respiration, can really have a positive effect on when and where you experience the pain, or if you experience the pain, or to what degree you experience the pain.
Yeah, that's really important because it does change the resting states of nerves. It does a lot of chemical changes. You end up in like sympathetic states, tone, everything's on red alert, all those different time of things. And it just reminded me of a patient. So as a mechanical therapy practitioner, we can make pain move around, right? We look at, does pain move into the leg? Does it move into the back? It gives us directions, and we can move movements and positions to change pain, right? And move it in a direction to heal. Well, once I learned about the effects of CO2 and using capnometry and the capnode trainer in the system, I was actually able to do the same thing as just what you were talking about. I recalled this one patient. I had seen her for many different times, and she had pain going into her arm, which is a common symptom referral from the neck, right? But what was different about her is she had just got out of a rehab because she was addicted to opioids. So she was addicted to opioids, went to this whole program. It was horrific, because it's cold turkey. They just slammed her in there cold turkey, and she had to go through this whole thing. It was a major experience. And so I'm sitting there thinking, and she has her pain. So before I did anything to her neck or anything like that, because of what she'd been through and how she presented, and I kind of knew her already, super, she was very anxious, when she came in and some things like that. I'm like, let's just put her on the capnometer and let's just see what happens when we bring her CO2 levels up to normal and educate her a little bit and acknowledge what she's been through, right? Just normally before I would have might have just honed in on her neck pain, right? And okay, let's get this done. And that other problem is the other problem because um, we kind of go into psychotherapy, but there is a line, and so you're always kind of looking at that. But what happened was it was amazing. So when I brought her CO2 levels up, her pain went away completely. That pain that just like I would have done with repeated movements or things just went away, right? So the irritation, sure, she had an irritation, probably in her neck or that. But what was more important is her nerves were sensitized. The changes in her physiology because of the low CO2 now, they made them fire more rapidly and be more sensitive. And since she'd had that before, whether it figured her how to get to therapy, I don't know. You can go into all kinds of philosophical and psychophysiological ways that she came in, but and I've done it many times since then. So now when I see that person, especially if they're moderately severe in their loss of CO2 and I see other factors, then I go straight to that first. And then that opens up the picture for what I might normally see in therapy. So I've seen many like that. It's quite profound.
Now, you were mentioning to me one time, quite a while back, that you looked at the percentage of people with chronic pain who also suffered with the effects of hypocapnia. I can't remember what those statistics are. Maybe you could comment on that.
Yeah, well, when it deals with the head and neck, okay, like head and neck problems, it's like 85% plus, okay, that are moderately severe hypocapnia, right? So it's not like something you can't look at. Like now that I know, I would be negligent as a therapist not to address this, right? The problem is I didn't know before. And then the same thing in the lumbar spine, but just not quite to that degree. It's more like around 60%.
Well, that's extremely high, and it becomes it. What you're saying, as far as I'm concerned, is that physiotherapists or people in rehab, where you're dealing with pain, that it should just be a standard routine thing that professionals do to see whether there is dysfunctional breathing that has been learned and is exacerbating that pain or triggering that pain when it otherwise might not need to be triggered and so on. It just, and if you're not looking at breathing as behavior, you're not likely to think this way. it's not likely to occur to you that your patient has learned something that's having a profound effect on the primary symptom that you and your patient are trying to manage. And it's just a travesty, I would say, that no one is looking when it has such a profound effect. You remember some of these statistics, for example, I mentioned so many times. 60% of the ambulance runs, say in New York City, are a result of dysfunctional breathing, where you get hypocapnia and a lowering of CO2 and these radical symptoms where then people don't know what's going on. They call 911, they end up in the hospital. Well, you can imagine that happens with paying patients, that they're much more likely to be breathing that way and get those symptoms. And no one is even recognizing, you know, all these emotions and all these physiological changes are coming from the way the patient is behaving while they're sitting in front of you, and you're blaming it on all this other stuff. I mean, that's really a tragedy. And I think it comes from not understanding that breathing is a behavior and it changes based on where you are, who you're with, what your history is, and so on. And we're not paying any attention to it. That's
Yeah,
my
for
message.
sure. Well, that was, it hit me like a ton of bricks. Once I did this, I always tell people I thought I was a decent therapist until, right? Until I realized there's a whole nother thing, behind the curtain. And just that patient in front of you and being able to see and understand all the things that can be going on, because many of the unexplained symptoms that low CO2 brings on are musculoskeletal, right? They're musculoskeletal symptoms. They're masquerading as these symptoms, whether it's from carpal tunnel to neck pain to headache to uh, nerve irritation to just anything, swelling, all kinds of stuff, right? Uh, and then how it actually affects their whole system over time when you have something major. When you're not seeing that effect, you're just ignoring it because you don't even know that it's there. So what I've tried to do in my career, and since I've learned this, it's kind of like my mentor Robin McKenzie did. He saw patterns, right? He saw patterns. He created systems around those. He helped now something I can use and see in patients. And the same thing is happening when we look at CO2 levels. Now we see patterns. Like I was just saying, we're doing research. We're understanding when it's like maybe the first thing you look at, or do you build it into their system, or it's not an issue, you put that aside, okay, now it's this, right? So every time you can rule out something, it makes you more effective. And then to help other people who are coming into this and they want to see this and understand it and put it into their practice, they don't have to start from square one so much like I did. They have a system and a way to do it, and then that becomes a full part. And then you get some people that, like I said before, they really need just that. I mean, we treat high blood pressure in our clinics. We treat test anxiety. We treat all kinds of different things, performance anxiety. But now, where we wouldn't have even thought about that. But now, then, when we see it, they come in and they either now doctors refer to us directly because they know we treat it and have good results without medication. But also, someone comes in and they have a problem and they also have high blood pressure. And because we check all things, we realize as their CO2 levels normalize, their blood pressure normalizes, right? At the same time. So we started to put those connections together, and then we can develop specific programs, or it's just an adjunct. Does that make
You
sense?
know, you mentioned unexplained symptoms, and the good thing about the unexplained symptom is the way that the practitioner labels it. They can't explain it, but think of all the symptoms that are explained, but they're explained in a faulty way. That the symptoms don't come from what they think they're coming from, but they're coming from the behavior that's mediating those symptoms, which are then attributed to the reason why the person learned the behavior. So,
Yes.
that's important to understand. It's not just the unexplained symptoms. That's okay, but when it's explained, and it's not appropriate, I mean, that becomes bad. So
Yeah,
we
well,
Yeah, and
like,
want
that's
to,
what
yeah,
develops into chronicity. That's what
right.
chronicity is, right? We have not addressed the right thing to help this go.
Right.
Sandra, you were going to say something?
Yeah, I was thinking about how you mentioned that until you started utilizing the cap no go and measuring people, you didn't know what you didn't know, like so many providers, you just don't. And so it's very easy for a provider to possibly make an unnecessary procedural recommendation unless they are monitoring CO2. So, touching on what Peter was mentioning as well there, and I was thinking of that client case that you had mentioned with somebody who was slated for surgery.
Yes,
And
yes.
I
So
mean, that's an
that's what just came to mind
incredible,
just then with
it's
that. So,
it's
mhm.
incredible. And it's so important for people to realize that lots of times there are, pe people prescribe a procedure because that's what they're trained to do, but they're also not necessarily looking at the client's breathing behavior and its role in contributing to why they may be prescribing a certain treatment that could be totally an unnecessary procedure.
maybe
So,
you could briefly describe that. Briefly, we don't
yeah,
spend a lot of time on it,
Yeah,
but briefly
yeah,
describe how you
absolutely. Because
it's
identified it,
amazing.
how you identified it as a behavioral issue
Hmm. Hmm.
rather than a strictly physical issue that required surgery, and just give people an idea.
Yeah.
yeah, and that's real important because we when in therapy and for most people, we do a test retest. We do a test, an intervention, and a retest, right? To see the effect on what you're doing. And that's very much what we do also when we work on people's breathing. So this patient, I worked with a prominent neurosurgeon in the area, and we would send patients back and forth. And so he sent me a patient and said, "What do you think? Does she need a neck surgery?" She had been in an accident, a motor vehicle accident that was not her fault, hit from behind. There's a whole cascade of things about that, but she was having symptoms in her hands, both hands and arms, as well as her feet. Okay, she would get numbness, tingling, and that is a sign of central cord compression. So when you're looking at if you have stenosis in your cervical spine, a narrowing, disc herniations, changes in facets, things like that, because she'd already had a surgery, right? She had had a prior neck surgery. Now then she's presenting, and he's not really sure. And I'm sure he saw some things too, maybe behaviorally, and especially when car accidents are involved, you have to really think about a lot of things because it brings other factors besides just what's going on with them medically. But basically, the long story short, it was my job to figure out whether she needed that surgery and could I reproduce that. So what I did is I looked at her CO2 levels. They were compromised. They were down. She, even just as she was talking to me, I could see her behavior and her responses to things change in front of me. With that, I could see it on the software. Lots of different things had it running, and I would bring her up and down and see what her symptoms are. But the biggest thing I did was I put her in the position that would relieve constriction in her neck. Okay, so like a flexion type position normally opens up the spine and it would make it better. And then there's other positions you would put them in to test that would make them worse. Like you would put them in a position to narrow their spine and see if that got going. But what I was able to do is once I um, saw that she was changing symptoms with her CO2 levels, I was able to demonstrate to her, which was very important, okay, not just to me and the surgeon, that her symptoms, I could make them come and go in a position of opening her spine, right? And then make it go down. And I could even get her, then I did the opposite and normalized CO2, abolished her symptoms, put her in the provocative position that should bring this on if she needed the surgery, and it didn't come on, right?
What's so
So
important,
just in
yeah,
that
what's
instant.
What's
we can
so
get that.
important, what you're saying there, is that on the one hand, if you didn't understand breathing as a behavior, you could see that when the position changed, you got the expected symptoms and you would have concluded, yeah, there's a physical problem here, he needs surgery. But what you saw is that the behavior changed. When they changed the position, the breathing behavior changed depending on what position you were doing the testing, where you saw the symptoms. And when you got rid of the behavior change, you got rid of the breathing change. Changing position didn't produce the symptoms. It was the behavior associated with, the changing of the posture, the change in the breathing behavior that was mediating the symptoms. It wasn't the position itself. It was the behavior. And that would have
Yeah,
been overlooked.
absolutely.
That would have been completely
Absolutely.
overlooked unless you understood that breathing is a behavior and it changes as the function of the trigger behind that behavior, because all habits, all behaviors have triggers. So there were triggers for that learned behavior that you teased out, making the surgery unnecessary. Is that correct?
That's correct. It would have been, and when you have symptoms in your feet, it's a major deal, from your neck. It's a big deal. It's like you need something almost as an emergency, but everything else wasn't necessarily adding up. And maybe for another therapist, they might could see that this doesn't look quite right. And I think maybe the surgeon was doing that, but using capnometry and understanding breathing behavior and how it may be a source of her having symptoms, just it's a game changer, complete game changer, and so that would have gone on. And then of course after that, he's sending me almost every one of his patients, right, to have this testing. He'd say, I don't know what it is, just do your thing, Denise, and let me know what you think.
This comes from just looking at physiology as physiology, not understanding that the most remarkable thing about physiology is the programmability of that physiology. That's what makes us living systems, is that we are programmable and that there's psychology embedded in that programming, like motivation. Pain is a big source of motivation. By the way,
Yes,
you
it is.
might point out, there was a study, something you did once with testing for vestibular disorders, and how there was a new instrument of some kind to look at vestibular issues, and how they were making a determination with this instrument or this system, this procedure, to determine whether there was a vestibular problem or not, all focused on the physiology without understanding the programming and learning that could be behind it. That amazed me. Maybe you
Oh
could.
yeah, that was huge. So when we brought on balance at a high level into our practice, we bought a thing called a CDP. It's a computerized dynamic posturography. It's a $200,000 piece of equipment that is the gold standard for somatosensory organization test, right? And so when you're looking at balance and vestibular problems, it's our eyes, our vestibular system, and our joints that keep us upright. And this machine can actually move the floor, right, and put all these things into you to kind of see which one is working the most, which one isn't. So I go to get training on this with Dr. Nasser. This was actually made for with NASA, okay, back in the day, how this all came about. And so I'm sitting there studying, and they're talking and they're going through this, and we go through all the different aspects, and then he says, we have two non-physiological issues that's what they called them. Like that was actually the category, non-physiological causes, and they put them in that. Now, you can go back as far as when I first started studying, it was called inorganic. It's all changed. It's still, maybe we don't know what it is. It's not explained, right? And so I was, tentatively, but I kind of slowly raised my hand. I'm like, I don't think it's really non-physiological. I think that we can look at it and explain what it is. And so we went on to do that in our practice, and we'll actually use the Capno trainer while they're on that or in therapy, because many times with falls, it's you have a lot of fear, right? You have a lot of fear, a lot of triggers, adaptations, changes. It's scary. You fall and break your face. Don't think that you're not going to have fear or trauma. That's any individual on the planet, right? And to think that that can happen again without control, whether it's forward, backwards, break your hip, whatever, your grandma died from it, all these things. And so we were able actually to create that category now where we don't have that issue. We know the cause of that non-physiological outcome.
Well, it was interesting that what you were telling me about is how in this one case they diagnosed this man as having a vestibular issue, only to find out that what happened is when he walked, the CO2 level dropped, precipitously, and he flunked the test. But when you then coached him in restoring optimal respiration, that is bringing up the CO2, which moves the respiration into that category, he passed the test. And so
Oh
that
yeah.
the diagnosis was just completely off the mark because they never considered the behavior that the client had learned. I mean, for me, it's what's important in all of this is to understand that physiology is a behavioral phenomenon, is to understand that it's programmed and there's just this, and it's habit driven and habit regulated. And it can be very difficult to address a habit. Once it's there, it's a physiological reconfiguration. It's not in your mind. It's in the physiology. It's actually in the body. That's where it is. And it's a psychological happening in the physiology itself that it's there to understand. So no one's saying everything is caused by bad breathing. No one's trying to say that. We're trying to say that you need to look at programming of the physiology, and the breathing is an excellent example of how when it is programmed, it can really mess things up. And if you don't identify it, you start blaming it on other things and you don't get anywhere as a result. Or if
Yeah,
you do,
exactly.
it's
Mhm.
coincidental. Anyway,
Yeah, so I mean, on that specific patient, there was two that day. I went to a balance center and I'm observing, I'm learning this, right? I'm not a neurological therapist. I'm an orthopedic more oriented therapist, right? So, um, but I went to another place at physical and I'm watching in Florida, and this lady had been in care for over 8 months. She was a CPA who'd fallen backwards and hit her head. The chair broke, fell backwards, hit her head. Can happen to anybody, right? And so she had gotten to where she had this very abnormal gait that they were working with. And I know enough about neuro. When I looked at her gait, I'm like, this is not normal. I mean, I don't know what neurological condition would cause that, but I don't think so. And then I'm seeing her and I'm like, oh, I wonder, right? So what we did was we had her go through she had to do these step overs and things to test her balance. And I looked at her CO2 levels and they were low, brought them back up, had her do it again 3 times and helping her to understand that she had control over that. She didn't have to necessarily react or interpret it that way. Just concentrate on this. Because what you were saying, Peter, it's very important for us. You have to not give people another problem, right? You got to be very careful about making them think that this is a psychological problem, that they have somehow created something and they're doing this. That's a very important, just to touch on that, to help people realize and get a handle on something, but not make them at fault for it. That doesn't help, right? By explaining these things. So, anyway, right before our eyes, and they're filming this because they'd never seen anything like this, two things up and down, and it completely normalized her gait, her ability to step over something. The whole thing completely went to normal. You could have knocked me over with a feather at the time because I was kind of getting into areas that weren't my core thing, but I knew enough to do that. So it was very remarkable. And then as you look into it, you understand why it would have such a profound effect on that.
I mean, the physiology of it is just plain and simple.
Mm-hmm.
Like everybody knows if you start to take breaths that are a little bit too large, you start to get dizzy. That's because, you've reduced blood flow in the brain, you've reduced blood volume in the brain, you get disoriented, And when you get disoriented, that can make you anxious too. What's happening to me? My God, I don't know what's going on. I never seem to be able to do well in this situation. And you start, cognitively attacking yourself or being incompetent, or, you can't focus, you can't think properly, or you can't walk properly. And so now you overventilate even more, lose more carbon dioxide, and you become disabled in essence in a very short time. Nobody really understanding what's going on. And it's very subtle. It's not as if when someone loses carbon dioxide, you just look at them, say, oh my God, they're doing this. It's something you can be breathing at 4 or 5 breaths per minute. You can be in a meditational state uh, from a breathing perspective at a very low breathing rate and have compromised respiration severely.
Yes,
Anyway,
and it can be episodic as well. It can change very quickly.
right.
If we
Just
have
right
time,
in
I
this
have
way.
one more patient about that
Please,
at that same
please.
time.
Go ahead.
So there was a gentleman there. He was an older gentleman. He has very accomplished man, had been a pilot, had done all kinds of things, and he had been in one. He survived one plane accident, and then he had fallen and hurt his head. So he actually had scar tissue inside of his head, right? That they knew was that, and they were sitting there and they were doing what they call it's a dynamic visual acuity test. Like, so it's a machine and it regulates and it says you move your head, right? Can you keep your vision? Does it get compromised when you're moving your head back and forth? Very important thing. So like when you're walking, if you turn suddenly or just not even suddenly, just the speed that we normally turn, what happened? So the lady was telling me, she's like, she's actually talking to herself. I'm just standing next to her, great PT. And she's like, I don't understand this. Like some days he passes this and he's great. The next time I test him, he's horrible, and it's like, and I'm sitting there thinking, oh, okay. And I'm understanding the trauma and I'm thinking about that maybe more compromised vestibular artery, right? That goes through his scar tissues. I found out where it was. So it would be a lot more sensitive to changes in flow because it's already compromised, right? So we were able to do the test. He didn't pass, bring his CO2 levels up to normal, and then he passed just fine, right? So it was just that simple, that quick, and it gave them an understanding of why that may happen. And we're probably seeing that in clinics everywhere all the time, all over the world, right? And that's why it's important to try to get this in a way that's deliverable and can help people understand breathing behavior, its impact, how it may lead you to treat the wrong thing or treat something longer or keep you from being effective. You're a really good, effective therapist treating the wrong thing. I did it many times.
Wolf, do you have any comment or question?
Yeah. I mean, I really like how the discussion so far has pointed out the profound importance of breathing in all kinds of physical therapy related challenges and working fields. I mean, you have so much experience, Denise, that for me it's just a pleasure to listen to that and to hear all those different examples. And and it's also kind of frustrating, right, to see how breathing behavior might be overlooked in the medical profession or whatever kind of close to medical or providers that try to support people in all kinds of ways. And a question that was coming up to me was like, people come to you because they have a clear understanding, maybe from their doctor or from whoever, what the problem is, right? So they have a problem with the knee. And then they come to you and you do whatever you do. You do your testing, you do your evaluations, and then you start working with the breathing with them. So I was curious how people respond to that, because when clients come to me, they know I work with the breathing, and when people come who have breathing issues or have chronic or acute pain issues, we also work with the pain and see the connections like you were describing. But I I have no idea how, for you as a physical therapist, where people have a very clear idea what they want from you. When you come and you identify and say, okay, your greatest barrier to recovery, which I think is a brilliant term, and I think it really reorganizes the way we think about helping people. And I really like that. How do people respond? I mean, are they surprised? Are they frustrated? Or are they curious? Or, I'm coming from my
All of
knee.
it.
Why are you telling me this?
All of it, right? We've had every response out there, right? And it kind of depends on what their levels are to beginning. Because if they're already hypervigilant, uh, not really present, very anxious, now they're like, they're irritable. I mean, these people are very irritable, and you're sitting in front of them, and that irritability is coming to you because they're like, yes, I had hurt my knee. My doctor sent me here. Why are you talking to this about me, right? But what we do is, in general, as physical therapists, we look at all vital signs, right? So we look at their O2 levels, we look at their blood pressure, we check about their insulin levels. Do they have diabetic? All these different things to make sure that that person is okay for outpatient physical therapy, right? And I kind of see CO2 a lot of times as a sixth vital sign, but we can get into that later, right? Because we have the ability to look at it. But we also treat people as whole people, right? And talk about like understanding with them what they're going through and creating that therapeutic alliance, and that they're depending on us to bring our knowledge to their condition, right? And so when I'm able to put it that way, and I tell a lot of stories to patients, I don't go into the things like we talk about here. I tell stories, right? And that way, that person can put themselves in that story and see something outside of them. And I'm not having to talk about psychology, physiology, behavior, any of that, because they would be like, I'm out of here, right? I came here for my knee, right? So, but when you talk about responses and what people go through, that's just a normal part of humanity, that any of us would respond like this, and that this is a response, and we get into education about sympathetics and parasympathetics and just how we negotiate and get around. How do you deal with pain that doesn't go out of the room? The lion jumps in the room, it doesn't go out. How do you go through life with that there all the time? There's going to have to be some accommodation in our system to cope, right? So that's when I can really help them to understand this is one of our coping strategies. It's a way we deal with certain things. Maybe not because we want to, just because that's where our body's programmed to help us. But sometimes what we do to help causes the problem over time. Like, use a simple analogy, like someone with knee pain. If they continue to walk abnormally, they're going to continue to promote their knee pain. It's not until you normalize their gait that now the knee that couldn't get better gets better. Because anytime you do something with the body that normalizes how it functions, we know that that input into the body changes things and interprets, and things start to heal. And the breathing's not really any different. And once I kind of come at it that way as a whole person, and realizing it's not something there, not blaming them or helping them to see, just educating, they change, and probably the majority of it respond. And then I just ask them if they would mind us looking at this to see if it's a possible factor that's contributing to their suffering. And so when you talk about people suffering and something that might contribute to it that we could identify and help, then they're all in, because now you've recognized that they are suffering. And we need to look at all aspects of an individual to help them. But if you don't do it like that, you can really have a patient storming out of the room, and the doctors are calling me and cursing me out about, what the blankety blank are you doing over there, Denise? I sent you this and you're doing this. Yeah, I've had that too.
Well, I think the message is that we need to get people, physiotherapists, and the whole domain of physiotherapy more focused on their clients' behaviors and what they learn unconsciously and how symptoms get generated as a result of that. And specifically breathing, because the effects are so profound, so immediate. And not only that, but they're subtle very often, and they can influence personality and emotion and cognition and all of these things. And I think it's important also that the general public be more in touch with how breathing actually can so profoundly affect them so that when they come to physiotherapy, they can ask questions. Maybe my breathing is involved in this. So they understand their physiology in a little more, in a more profound, personal kind of a way where they can participate and be part of the process and trying to find out what's going on and what they can do. And by the way, today we've been talking about pain, but I just want to remind you that in a couple of weeks, we're going to be talking about breathing and music, which is quite different, that Wolf will be talking about in a couple of weeks. I didn't want to
So,
forget that, so I thought I'd jump into that for a second. But anyway, I think that what we're talking about here in physiotherapy, both patient and therapist, it's so important to understand the relevance of breathing. It's unlike other behaviors. It really has an immediate and profound effect on you. And it's so easily misunderstood and misinterpreted and not addressed. So we really want to get the word out there to all of you to spread the word. Come and have your friends listen to the YouTube on this so you can hear what we've done here today. I think it really is important, very important. And it's just an example of how, breathing itself is such an important thing to look at. That's why we've created On the Air. We're trying to get the word out. And this is really about breathing behavior analysis that we've been talking about today. It's a very exciting thing. And, we hear over and over again how to breathe this way or breathe that way to relax or control the parasympathetic nervous system or something. And what you're doing is you're just manipulating the physiology. You're not understanding the physiology as a behavior that's learned unto itself. If you're just using it as a tool, like using your arms, for a tool to do stuff, that's great. But, the breathing is part of who you are as a human being and how it's affecting you from moment to moment in such profound and subtle and long-term and immediate kinds of ways. How many people are really aware of that? This is really what we've done today is a really good example of how it comes into a profession like physiotherapy.
Very much so.
I really like the term therapeutic alliance you mentioned, Denise, because it says a lot. It brings this, it's a team effort. You can bring some information, and you were mentioning that you're educating your patients, right? And I
Yes.
have hardly ever heard that in relation to medical treatment. But I think that's very, very, very profound, and that's very, very illustrative of what it involves to work with behaviors. That is so important for Peter, because you need that alliance. You need that kind of how do you work in education? Nobody else can learn something for you. It has to be you who will learn something. You have to understand physically and embody and embrace mentally and emotionally the importance of that, what you want to learn or what you're trying to deal with, right? So, and I realized when I was listening to the communication you have with your clients, how I do it, Denise, because I realize when I talk about behaviors and how behaviors can be important levers or how they can contribute to improve health and performance and whatnot. It's something that, of course, if it is related to be a behavior that is either your greatest barrier to recovery or your greatest barrier to performance or whatever, right? Then it means you don't need a medication that might have side effects. You don't need a surgery that comes with a lot of risk. So changing behavior has this beautiful aspect of the least risk involving a way to deal with those things, right? So it needs courage, right? It needs courage to
Yes.
work with your behavior, to work with your personality. Like Peter gets so excited about breathing his personality, right? And changing your breathing means changing your personality. So that is a very courageous thing in the first place. But at the same time, it's something that, you will carry along for maybe the rest of your life without having to suffer from whatever kind of side effects, having to suffer from whatever might, happen in a surgery and so on and so forth. So I think this is a really beautiful thing of working with behaviors, that it makes us more curious. It makes us more, aware, and it's kind of less at the least risk strategy. I would put as an
I
advantage
mean,
and as
it's something,
an argument in favor of it.
what you're saying, is that the behavioral side should come first. I mean,
Right,
surgery is last. I mean,
right.
looking at it behaviorally is doesn't cost much, and it's you can very quickly make some kind of an assessment rather than going through these endless physical tests and then ultimately taking drugs and surgery, and in the end, nothing worked. So you say, well, let's try this behavioral stuff. Nothing else worked. It
Mm.
really needs to be the other way around. The other way, you look at the programming of a system. If you have a problem on your computer, what do you do first? You're looking at the software. Then ultimately, you may have to look at the hardware. You may have to replace a hard drive. You may have to do something, but that's not what you look at. You're really concerned with the software and how it's been programmed and what you did wrong and all of that. You start there, and then if you have to buy a new computer to buy a new hard drive, well, so be it. Maybe you lost all your data. But the idea is that you go there after you've exhausted the programmability of the system, which is the most interesting part of being a living organism, is how we are programmed and how it can be changed. And even healing, in the human body can be involved in programming itself, how and when you heal. Looking at immune system functioning and learning in the immune system, is profound. I'm not going to go into that, of course, here. But anyways, Sandra, do you have any closing remark you might want to bring on?
Well, I really appreciate hearing the client examples and also just that you shared, Denise, just for other providers as well to have an understanding of options to be able to include utilizing breathing in a clinical setting that could be applicable to each profession's expertise. I mean, you mentioned it in a very general way, but that could generally be applied to a lot of different professions where you're doing interviewing, you're assessing, you're monitoring, you're retesting, you're applying therapeutic approaches as well as using breathing and instrumentation where the client is very much involved in the process rather than just being physically manipulated in some way and hoping for a good outcome. And then they
Yes,
go home and eat their Twinkies.
right, right. Yeah. Yeah.
So,
So yes,
yeah.
for sure. Yeah, we need to that alliance that we were talking about, requires trust, right? And they help you do that. But many people really just need to be in a state and have education so that they can understand it. And many times when we use instrumentation or it's like a biofeedback device, them seeing it and understanding it and seeing how it's lower and what they have and starts to work with their behavior and physiology as they're taking that in. You see it change. I mean, I spent years teaching people exercises to do things, and some of the exercises are hard to get, right? And how it affects their pain, and especially posture. Posture has a big effect on lots of things. It's very simple, You're like, okay, you're going to change my posture. Thanks a lot. I paid you for what? But anyway, but it can have a really big difference in the biofeedback and the understanding of their breathing with just changing their posture and how it works. They correct it on themselves. They don't need me to teach them an exercise. It's just spontaneous. They get it, right? It just puts it together. But one thing I did want to mention when we're talking about pain is many people are on meds, right? In the medical world, it's pain medication, right? And we had the whole opioid crisis. We had the whole thing. We're still in this, right? And so many people come to us quite medicated. And one of the things that we noticed very quickly as we looked at them with capnometry is the people on the opioids had perfect CO2 levels. Okay, they're perfect, right? You can't do anything to make them go good or bad. They're just stay perfect, right? And so you're looking at an altered state. And so I had this one patient that he had had surgery and had back surgery, major thing. He was having all these different symptoms, getting sick. He was blaming it on the meds, all these different things. And then when I put him on, he was like perfect CO2. But he was like having severe constipation. You have severe side effects, right, to a lot of these meds. They're not just for one thing. So he trusted me enough to say, let's take the meds out. I want you to just not take your meds for 24 hours. He immediately started pouring sweat, right? He's just like, oh my gosh, I'm going to die, right, if I do that. Because if the pain is this bad while I'm on it, he's thinking, how bad is it going to be when I'm off of it, right? But what we're able to do is get him off of it, have him come in. Now I'm dealing with his normal physiology, like how he is presenting today, right? Without being medicated. And long story short, we found out that his dizziness, vomiting, the level of his pain, which was stated at 8 to 10 all the time, even with pain meds, we were able to bring all that down to like a 3, manageable. We took his sickness away. We took his dizziness away. We could make him stop vomiting. I mean, he's vomiting. He's vomiting in the treatment room, right? He's gagging, he's having all these things going on. And just by now that we could really look at it and help him understand how to change his breathing behavior and how it changed things, that within 2 weeks, the man was golden. He was off his medication, no more constipation, all that done, all those different things. So I'm just really grateful. But just for people out there, just so you know, when you're seeing something on meds, whether it's marijuana, opioids, whatever it is, it's not a normal situation.
Well, thank you, everybody. Thank you, Denise. And we're glad that all of you are here today. And for the people who'll be watching this in YouTube or from the On the Air website, we'd love to get some feedback. Let us know what you think. Really appreciate it. And in any event, I think that will close today. So Keikishaw, if you could close it out.